Ladies and gentlemen, thank you for joining the Lake Superior Quality Innovation Network Office Hours Hospital Readmissions Report webinar. Your host for today, Ross Gatsky, will begin.
Thank you. Good afternoon, everybody, or good morning to some of those in the Central Standard Time Zone. My name is Ross Gatsky, and I'd like to welcome you to today's Office Hours call for the Quarterly Hospital Readmission Report, which is presented by the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN is comprised of three organizations: MPRO in Michigan, Stratus Health in Minnesota, and Medistar in Wisconsin, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement. We wanted to offer you this call today as an opportunity for you to learn from your peers on how they are using the the quarterly readmission reports, and answer any questions that you may have. Also, the feedback that we received today will be very helpful for us to make any appropriate changes to the report, to add any value that we may have missed. There is an evaluation survey at the end of the call, and we would greatly appreciate you complete that short survey to provide us with some of that feedback. Also, the session is being recorded and will be available for viewing on the LSQIN YouTube page in about 2 weeks. So from this learning session, we hope to accomplish the following objectives. First, we want to provide important deadlines and resources relevant to acute care and critical access hospitals. We also want to offer the opportunity for each of you on this call to learn from your peers on how they are using the information in the hospital readmission reports to drive quality improvement efforts. And finally, we want to provide a question and answer session in which you have the opportunity to interact with not only us at the LSQIN, but also your peers, to go over any questions, concerns, or offer any feedback that you may have in regards to these readmission reports. So I think what we're going to do today is, and this might be a review for some of you on the call who may be more familiar with the reports, but I think it would be helpful for us to provide a brief overview of the content within the report, to inform anyone on the call who may be completely new to these reports, or provide a quick refresher for those of you that are more familiar. If you would like a more detailed explanation of the content within these readmission reports, us at the LSQN did hold a webinar specific to a more deeper dive of the report content. We held that back in April. And we will provide a link to that webinar on the LSQIN YouTube page in the chat box. So very briefly, we'll go over the report to make sure that everyone on the call has at least some understanding of the report content. So starting with the cover page of the report has the name of the hospital and the CMS certification number, or CCN. It also has the name of the county that your hospital is located in, or if your county is participating in a coordination of care coalition, it has the name of that coalition. Many coalitions are county-based, but for those that are comprised of multiple counties, it includes analysis for those counties. And finally, the overall time frame of the report is at the bottom. And just keep in mind, the most recent report that you folks have received would be from quarter 2 of 2015 through quarter 1 of 2018. So the time frame on the report that I'm using as this example is from an older report. The table of contents is fairly self-explanatory, so I don't think I need to go really too deep into this, but I do think it's helpful to note that the report is broken down into two separate parts. You have the trends for readmission, and then you also have those for utilization. And for the folks in Wisconsin, there is a third part, which we will speak on very briefly at near the end of the call, in regards to the new analysis on adverse drug events. The introduction of the report provides definitions and explanations for the report contents. This is really the go-to resource that you should seek out if you need more information about not only what's in the report, or how things are defined. Also, I want to mention at the bottom of the introduction page, there is a new resources section. where there are helpful links for the, once again, that webinar that we held back in April that really provides a deep dive about the report contents. There's an FAQ about, once again, the report contents, a link to the complete ICD code list, and then just another link for some general information about the LFQIN coordination of care work, which really relates to the content within this report focusing on readmissions. So the first page in the report, it just has some readmission analysis, is Chart 1, which is the Quarterly Hospital Readmission Trends. Just a reminder, the analysis in this report pertains to all Medicare fee-for-service beneficiaries that were admitted to your hospital as an inpatient. Very basically, this chart gives you a historic look at your hospital's readmission rate performance over the last 12 quarters or 3 years. Your hospital's readmission rate is compared with that over the state and with other similar hospitals. So, for instance, if your hospital is a PPS hospital, you will see the average readmission rate for all state PPS hospitals in that given time period. And if you're a critical access hospital, you will see the average for all critical access hospitals. There is also a dotted trend line. It's right here on the chart. And that indicates the trend of your readmission rate over this 3-year time period. So if it angles up like it does in this particular chart, then it indicates an increase in readmissions over this time period. And finally, just to mention something for this call, there are slight differences between the PPS versions and the critical access hospital versions of these reports, but for time purposes, I think we'll just be focusing on the PPS version. So this table is simply a different format of the previous chart with the raw numbers for the eligible discharges and readmissions with the corresponding readmission rate for each time period. So once again, for the PPS versions, this is broken down by quarter, and for the critical access hospital version, it is broken down by rolling 4 quarters. Also, you have the aggregate readmission rate for the entire 12-year period, or I'm sorry, 12-quarter period at the bottom, which kind of acts as like an average or a baseline for your hospital's performance. So when looking for quality improvement opportunities, you would want to identify some time periods that had significantly higher readmission rates than your overall average. This Table 2, the Detailed Readmission Snapshot, Part 1, is where we provide some more in-depth analysis about your Medicare fee-for-service patient population. This table displays demographic breakdowns based on categories such as race, age, and sex over the last 4 quarters. So for the report that you've just received recently, it would be from Quarter 2 of 2017 through Quarter 1 of 2018. This table provides the number of eligible discharges, readmissions, and corresponding readmission rates for each of the demographic categories. This table can help you identify any specific patient segment that has disproportionately high numbers of discharges or readmissions, which can allow you to target certain patient populations to focus on for quality improvement efforts. Also, there is a state rate for each of these categories on the far right-hand side of the table, which allows you to compare your hospital's performance with that of the state. Table 3 acts as a continuation of Table 2, but this table is centered around patients by diagnoses. In this table, there is a list of some of the more common diagnoses that are related to high hospital readmissions, as you can see in this portion of the chart right here, or table right here. Any Medicare fee-for-service patient that is discharged from your hospital within this time period who has a diagnosis of one of these conditions will be included in the analysis. The diagnosis does not have to be a primary diagnosis at admission, at discharge. It only has to be documented within that patient's problem list. So that's why these diagnoses are labeled as any diagnoses. A single patient with multiple diagnoses included in this chart will be represented for multiple conditions. Much like the previous demographic table, statewide rates are also provided in the last column for performance comparison. And in terms of quality improvement, once again, identifying diagnoses with not only high patient discharge volumes, but also high readmission rates would be a good place to start. So, for example, if we look at this, if the overall readmission rate for this hospital is, let's just say, 16%, identifying diagnoses within this chart with rates over 16% and high patient volumes could lead to efforts that have the most beneficial impact on your overall hospital readmission rate. So by looking at this table, for example, we can see that hypertension is responsible for a significant number of discharges with 1,893, and it also has a relatively high readmission rate at 19%. So that would be probably one of the logical places to focus on at the beginning. The next table in the report categorizes the top 10 clinical categories by discharge count over the last 4 quarters of data. The diagnoses in this table are primary diagnoses at discharge. For each diagnosis, the amount of discharges, readmissions, and corresponding readmission rates are displayed. And once again, we also have the state rates as well. For instance, so this could be used to kind of tell you what the primary diagnoses that are responsible for some of your higher readmission rates. Table 5, the top 10 diagnoses discharges by setting presents looks at the top diagnoses by number of discharge, so that same 10 diagnoses from the previous slide, and lists them to which setting they are being discharged to. The setting categories are home, skilled nursing facility, and home health agency. We also see that for each discharge setting, there are a number of readmissions and readmission rates. And just a quick reminder, you may see some of your cells within this table that have the word suppressed in them. This is due to the values in these cells being less than 11. And since these patients can be deemed as implicitly identifiable, we have to suppress those values. This table can be helpful in that it provides information for patients of certain diagnoses and where they go after discharge from your facility. So just really, it gives you an idea of what patients to target by diagnoses and where they go after discharge along the healthcare continuum. So the next table represents the state averages for the top 10 diagnoses by discharge listed for your hospital in those previous 2 tables, and displays the discharge settings and respective readmission rates for each of the diagnoses. So this really allows you to compare your hospital's performance with that of the state average for the diagnoses and readmission rates by setting type. This next chart displays the 30-day any acute care utilization rate for your Medicare patient population. We identify any acute care utilization by aggregating all inpatient admissions, ED visits, and observation stays within 30 days of hospital discharge. So for patients discharged from your hospital, if they had any of these encounters, an inpatient stay, an ED visit, or an observation stay within 30 days after discharge, that would classify as any acute care visit. So this table really helps to give you an overall idea of how many of your discharged patients are using acute services within those 30 days post-discharge. So for the PPS version of the report, much like the readmissions trends chart, the any acute care utilization rates are listed by quarter and compared with the state rates for the last 12 quarters. Once again, also there is a trend line indicating the overall trend of any acute care utilization rates across this entire time period. Table 7, the quarterly hospital acute care trends after discharge, just provides a table with raw numbers that are used in any acute care utilization chart. In this table, for each time period, in this case, since it is the PPS version, it is by quarter. There is a breakdown of any acute care utilization categories. For every time period, we have total number of inpatient admissions, ED visits, observation stays, and then those are aggregated into any acute care within 30 days of discharge. And then we also have the overall rate at the right hand of the table. The next two pages of the report are kind of an offshoot of any acute care utilization trend analysis. Starting with Table 8 of the report, we have the table for the top 10 clinical categories for inpatient stays by discharge count. It lists by number of discharges the top 10 most common diagnoses responsible for inpatient stays. And then for each diagnosis, readmissions, raw numbers of readmissions and readmission rates are listed along with the state rates for comparison. ED visits and 30-day ED emergency department utilization rates are also available along with those state rates, and then you also have any acute care within 30 days of discharge, those readmission rates, and those state averages for each of the diagnoses. The next table of your report lists the top 10 clinical categories for emergency department visits. So listed on this table are the top diagnoses related to ED visits for patients discharged from your hospital. These clinical categories are somewhat different than those that are responsible for inpatient visits, as for obvious reasons, more of the diagnoses that are related to having a patient go to the emergency department are related to certain things such as pain, fractures, or other injuries. And once again, for each of the clinical categories, there are totals for the inpatient stays, and then finally, we have the aggregated any acute care numbers, their rate, and then the state rate at the right hand. So, for those of you that were in attendance who are more familiar with the readmission report, thank you for your patience. We just like we said, I thought we understand the last 15 minutes or so was more of a review, but we wanted to offer an opportunity for those who may not be as familiar with the reports to gain some background and knowledge on the report content. And once again, we will have I believe the link is in the chat box for that April webinar that we held specifically on the content of this report. So something we strive to do for here at the LS2N is to add value to some of the products that we put out, and we felt that adding some content related to adverse drug events, or ADE for short, would add some value to these readmission reports. So there's a lot of attention being paid around high-risk medications, as you may know, and especially opioids. So we felt that adding some content related to these topics is something that we wanted to pilot for these readmission reports. So starting with the Wisconsin hospitals, we have, at the latest distribution of the reports, we've started to add some of this ADE content. So the analysis looks at the number of ADEs that occurred for patients admitted to your hospital. And ADE is, once again, an adverse drug event which is associated with one of the 3 high-risk medications, or HRMs. For this methodology, the 3 high-risk medications are anticoagulants, diabetic agents, and opioids. An HRM beneficiary is a Medicare fee-for-service beneficiary prescribed with at least 3 medications, with at least one of those being an HRM, so an anticoagulant, an opioid, or diabetic agent. So to get the ADE rates, it is determined by taking the number of discharges of HRM beneficiaries with an adverse drug event caused by either an anticoagulant, an opioid, or a diabetic agent, that proportion over the total number of discharges from your hospital of HRM beneficiaries. So it's not the number of ADEs over your entire patient population, just the number of ADEs over the total number of your high-risk medication beneficiaries. So as I mentioned, there's a lot of attention being paid towards these high-risk medications. Another reason why we felt the need to at least test the ADE content within these readmission reports is simply due to the fact that high-risk medication beneficiaries are being readmitted back to the hospital at a higher rate than non-high-risk medication beneficiaries. So this patient population is quite relative to beneficiaries with multiple comorbidities in terms of acuity, health, and readmission rates. And given this, which presents itself as a theme of the readmission report, we again find value in identifying population segments that have higher readmission rates because, once again, targeting these patients offer the greatest areas of improvement and potential impact to improve your hospital's overall readmission rates. So we've added 2 simple pages related to the ADE content to the quarterly readmission report. And once again, this is just, we're starting this off with Wisconsin hospitals only. So chart 3 provides a visual chart of your ADE rate of your hospital over the last three years of data. And this chart is much like the readmissions trends chart in the 30-day any acute care readmissions chart. You have your hospital average and your state average, and then the overall trend, the dotted trend line, which indicates whether or not the overall trend is going up or down over this particular time period. And then finally, the final page within the report for the Wisconsin hospitals, we have the raw quarterly, which is for PPS hospitals, or rolling 4-quarter for critical access hospitals, the raw numbers for the ADEs, and the AD rates for each time period. So this table has the total high-risk medication beneficiary population for your hospital and the total number of high-risk medication beneficiaries that had an ADE to give you that ADE rate. And also for each time period, there are corresponding ADE rates for your county, and then finally for the state, to kind of give you a perspective on your ADE performance. So those folks in Wisconsin, feel free to let us know what you think about the new ADE content, and if you do find value in it, we would like to know if what you think. Obviously, you don't have to answer these questions or provide feedback now, but if you do feel strongly either way, simply reach out to one of the contacts in Wisconsin, and we'll be sharing that contact information at the end of the call. But like I said, we really find value within your feedback, and we would like to know what you think. So now we get to the portion of the call that we would like to hear from you in the audience. So if you have any questions about the hospital reports or its contents, if there's anything in the report that you maybe don't see that you would like us to focus on, and also we also like to know what you are and your team how you are using the data within these reports to drive quality improvement efforts or to document certain things. And then finally, it doesn't have to. Your questions or your feedback don't have to fall with any of these 3 questions. If you have anything else that you wanted to add or any suggestions, we are all ears. So if we could open up the lines for some questions, I think that now would be the time to do so.
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. There's one question that was in queue. Let me see if they really had a question. Jennifer, did you really have a question? Jennifer Mack? Maybe not.
No, I'm not. Okay. I didn't have anything in queue.
No problem. Again, ladies and gentlemen, if you have any questions or comments, please press the number 1 key. Ross, I'll let you know when someone joins, okay?
Thank you. Yeah, that'd be great. So one thing I do want to mention while we're waiting for some people to ask any questions that they have, the readmission report's distribution schedule going forward to the end of 2018 and into 2019 looks as such. So in December of 2018, we'll have the quarterly readmission report with data through quarter 2 of 2018. And then the next one will be in March of 2019, which goes through quarter 3 of 2018. And then the third one from now will be sent out to you folks in June of 2019 with data through quarter 4 of 2018. So we did receive some questions from some of our hospitals in our states that are related to some of the content within the reports. Holly, did you have one of those questions queued up?
Yes, hi Ross. We did get a question from Diane. Excuse me. So the question that she had was, for patients initially admitted to an inpatient prospective payment system hospital, then discharged to a hospice, but then readmitted back to the IPPS hospital, will the IPPS hospital be tagged as having a readmission?
Well, that depends. If the readmission occurs within 30 days of discharge from the hospital that had the index admission, then that hospital would be considered a readmission. So the purpose is, for this report, we kind of follow the same CMS methodology for 30-day readmissions. Once a patient is discharged from your hospital, that begins that 30-day window. They could be discharged to any setting, really. I mean, skilled nursing, home health, or just simply home. If they are admitted, and it doesn't have to necessarily be your hospital either, if they're admitted within 30 days of discharge to any inpatient setting, that would be considered a readmission for the hospital that had the index admission. So yeah, so that is a question that we get a lot. There's a lot of nuance involved as far as certain things such as hospital transfers. So a patient being transferred to another hospital, that would not be considered a readmission. But thank you for that question.
Great, thanks, Ross. I actually got another question that came in via email this morning. The question was about whether or not this information is risk adjusted in these reports.
That's a great question. It is not risk adjusted. We do understand that there's probably a lot of value in understanding the appropriate predictability of patients being readmitted based on certain risk-adjusted categories such as age and comorbidities and that kind of thing. But for the purposes of these reports, we do not risk adjust them. Another good question.
Again, ladies and gentlemen, if you have a question, please press the number 1 key.
Hi, Ross. This is Janelle here from Health in Minnesota. I have a question about the ADE data.
Yeah. Hi, Janelle.
Yeah, because we're considering whether we want to be able to offer some type of ADEs, adverse drug event, for our Minnesota hospitals. And one thing I wondered, and you maybe explained this, but if you would just repeat, where does the number of whether a person has an ADE come from. Is that from claims and how it's coded that there was an adverse drug event, one of their diagnosis codes?
Yeah, I'm going to kick this over to our data analyst, Rahul, and he'll provide some great insight on this.
So, Janelle, this is Rahul. To answer your question, we use ICD codes to determine if a person has had an adverse drug event. So we look in, there are up to 37 diagnosis codes in the claim, so we look in those diagnosis codes, and if they have one of the ICD codes that relates to an ADE or either an opioid, an anticoagulant, or a diabetic agent, then we mark them as an adverse drug event.
Yeah, and the diagnoses, those are included in that link that is within the introduction page, I believe it is. So the link is a spreadsheet that has a tab for the ADE diagnoses that are associated with one of the 3 high-risk medications. Thank you, Rahul.
Yeah, thanks much. And just for the Minnesota people, just let you know, we are looking at it, and we would want to know what you would find helpful. So we'll be interested to hear what Wisconsin people provide Ross and team for feedback, and if any Minnesota people have feedback or ideas, we would love to know as well. Thank you.
Yeah, thanks. So we're trying to we try to add certain things that have value from our perspective, but obviously that's for the people, the frontline staff, and then the folks working in the hospital facilities. We really value their perspective more because they know what they need to help them identify gaps in their care based on their Medicare claims population. And I think we have one last question that we kind of have queued up from our end. We want to thank everyone on the call today. So it's Natalie. Did you have the one?
Yes, and hi Ross. I have one other question that we've heard in the field a lot, especially from our hospital teams that have been presented this report to their community coalition. Comes up a lot, which is on slide 8. Ross, if you could go back to slide 8 for everyone to see it. On the detailed readmission snapshot, this is a pretty popular slide pretty popular table on this slide from our experience. And the question we get is, there's a population segment called multiple chronic diagnoses. And what diagnoses are included in this multiple chronic diagnoses segment?
And yeah, that's another good question. Rahul, if you would be able to kick this one off too, the diagnoses that are associated within the multiple chronic diagnoses category.
Yes. So what we do is we look at if a certain patient has had any discharge within the given time frame period with at least 2 of the following 4 conditions: AMI, COPD, pneumonia, or congestive heart failure. So they need to have at least 2 of these 4 diagnoses in any of the discharges during the time period that the report includes.
Okay. Thank you. So, seeing that we don't have any questions or any feedback from the hospital people, I think we understand, and we would like to provide the gift of time to everyone. We did want to thank you for attending today's call. If you do have any questions about the reports, or you do have some feedback that you'd like to provide, especially with the new ADE content, I think we would find that very helpful. So feel free to reach out to your appropriate state contact, and I have them listed here on this slide. And we'd be more than happy to assist you with that. I also want to remind once again that we have an evaluation at we'll be pulling it up right now, and we really appreciate you guys filling out this evaluation, and that helps give us some information and guidance on how to make these presentations more valuable. So Emily, could you please pull up the survey? Thank you. So if you could please just take the short couple minutes to fill this out, we would really appreciate that. So if there are no other questions, this concludes today's office hours call. Once again, the recording will be available in approximately 2 weeks on the LSQAN YouTube page at www.youtube.com/user/LSQAN. Once again, please take a moment to complete the evaluation, as the feedback that you provide helps us continue to make these quality events. Thank you for your time, and have a great day.
Thank you, ladies and gentlemen, for joining. You may all disconnect, and also have a great day.